if there's maybe some questions.
Thank you.
I think we were able to do that pretty quickly, so take it away.
Thank you so much. We recovered, and nobody goes home yet, okay? So my name is Arina, Dr. Bingeliene, and that's true. I do see sleep medicine patients 2-year-old plus. And today we'll be talking about narcolepsy pathophysiology. This is my part. Thank you so much, Ivan, for covering quite a few topics. So there will be some overlap. So repetition is good. I agree with that too. I don't have any disclosures relevant to this presentation. And the goal of this part would be to review pathophysiology and how we can be more target-oriented, more specific with treatments that are available. So, as it was mentioned, hypersomnolence as per international classification can present as narcolepsy type 1, narcolepsy type 2, idiopathic hypersomnia, Klein-Levin syndrome, hypersomnia associated with psychiatric disorders, with medical conditions, or induced by some substance use. And probably number one should be insufficient sleep syndrome or poor sleep hygiene, which is very relevant. Also, I will be very happy to share after this, our pediatric day will share a handout and you will have a copy of slides. And some slides I purposefully saved. They are more like review of some guidelines. They're busy slides, but I find they're very helpful sometimes to go back and look into. I do agree, I don't think we have a precise statistics for narcolepsy. It's underdiagnosed, it's missed, but so far we do believe that about 1 to 2,000 is the proportion of narcolepsy prevalence, and it appears that type 2 narcolepsy is about 2 to 4 times greater than type 1. There is no gender discrepancy. It looks like both female and male sex can be affected evenly. Interestingly, the diagnosis appeared to be pretty bimodal around teenage and then somewhere around 30s. And I was thinking, why so? So I think first part, when a younger child sleeps and sleeps a lot and no problems bedtime, usually parents don't come to you to complain. But when it starts to affect their pre-high school, high school, and potentially their future, everybody gets concerned. So my child sleeps all the time. So I think that's a first step. And I think there is a big problem, which there is no easy solution to. A lot of these patients do get to see psychiatrists first. They do get some antidepressants, which partially treat their symptoms, but they don't fully help. And they are labeled with depression, with anxiety, so there is a big diagnostic problem. And then they might carry it through life until they decided today is the day when I get hands on it and I discover what is wrong with me. And I'm in my mid-30s and I cannot function and I want to do it all, family and work responsibility. And then this middle-age group, people come to you and get a diagnosis. And of course, this condition can be in a way dangerous, depends what you do, but cataplexy or sleep attack can happen at a very wrong time and can have very dangerous consequences. And yes, it is lifelong, so we should be very careful when we diagnose it. We should not miss it, but we also should try not to overdiagnose it because it's a label for life. Two types of narcolepsy. Narcolepsy type 1 is with cataplexy, type 2 is without cataplexy. Interestingly, quite a high proportion of type 2 narcolepsy eventually develop cataplexy, so there is some overlay. So when you initially diagnose it as type 2, it might be actually type 1 with later presentation. Also, if initially there was a use of SSRIs, and then maybe you stop them for MSLT, you diagnose narcolepsy, but maybe over time cataplexy was suppressed by medication, and then you miss it. What is the different feature? What is the main defining factor between type 2 and type 1 and type 2 is the loss of orexin-producing neurons. Orexin and hypocretin is the same thing, discovered in 2 different places, 2 different labs around the same time. So I have both to respect both scientists who discovered it. And in type 1, you can see that orexin drops are barely found in CSF, but it is not a commonly used test. So we need to go by clinical presentation, I think is the main one, and then confirm it with PSG MSLT. So this is one of those busy slides that I will keep more for your record, and I'll let you to look at it, but I won't go in full details about it, especially we keep IH and Klein-Levin syndrome out of the stock today, but mainly both are chronic, both have to be sleepy, and cataplexy actually is a very unique symptom, except a few genetic syndromes. It's pretty much unique to narcolepsy. So if you can identify it and differentiate from seizures, from drop attacks, from other things, then you pretty much have diagnosis in your hand. History is very important. And the rest, there is quite a significant overlap. And we need to remember that sleep paralysis, sleep-related hallucinations, those are not specific symptoms. And somebody like a shift worker in teenage population, irregular sleep, poor sleep hygiene easily can present with those symptoms without any other underlying condition. So patients with narcolepsy are at increased risk of developing medical comorbidities. Sleep apnea is one of those as a result of obesity, as one theory, and they also at risk of developing hypertension. Later in life, also diabetes is a high risk, and then very high risk of developing psychiatric comorbidities to the point right now it's almost sometimes a question what is first, chicken or egg. And I think as you will see down in my talk that I think we are start to have some preview about future science, how neurology and psychiatry will meet again after separating for a few centuries, when we more and more understand genetics and biochemistry of certain conditions. And here's the slide about the cause of type 1 narcolepsy. As you see, it is likely. So what it means, we still not fully understand, but so far quite strong theory or opinion is that it's immune modulated or immune mediated condition in genetically predisposed patients. And what happens that due to this autoimmune process, we lose, or patients with narcolepsy lose orexin producing neurons in hypothalamus. And usually it is immune mediated with genetic predisposition, but a lot of cases are actually secondary. And it's very hard to identify what was the first trigger, but it can be autoimmune, it can be actually structural, it can be some severe psychological trauma that triggered it, it can be traumatic brain injury. And I would say still there must be some genetic predisposition, right? You take 1,000 people with psychological severe trauma, not everyone will develop narcolepsy. Here is our picture. I guess most of people already know this. So this is where it happens. We lose narcolepsy patients, not all of us, not in the afternoon today. So narcolepsy patients lose neurons in this area. And here's what I mean, like the more we understand and more we start to see how much we still need to understand and explain. But orexin is super important chemical to interact with all these little nuclei in our brainstem. And also there's strong connections going to frontal prefrontal cortex, which will explain a lot of symptoms that narcolepsy patients can have. So here you can see, for example, that when orexin stops to interact with acetylcholine, with histamine, with dopamine, there will be certain symptoms, right? For example, if it's dopamine a problem, motivation and the rewarding system is broken. When it's serotonin and the orexin are imbalanced, then depressive symptoms can show up, emotional dysregulation, etc. And I think I will here repeat a couple of things, but basically, how do we know that it's immune-mediated condition? So they were found HLA alleles, and the strongest is HLA DQB1 marker, which so far we don't use in clinical practice. Yes, it's available. It's not covered by ORHIP. I don't think practically we use it because 25% of general healthy population can have it as positive. So if you have a GERD unclear case in gray zone, this test will not help us really. And what else supports immune theory that narcolepsy onset has quite strong seasonal variation. There are a lot of reports about connection between flu vaccination. Definitely there were cases diagnosed during COVID pandemic and vaccination process. And also there is some association with other infections. And genetically, there is a found T-cell antigen that now confirms that there is a genetic predisposition. And big letters, type 2, we don't know what's going on. And I like this picture. Basically what happens is that when there is certain immune system cells activated, they are perceived and as safe to go through blood-brain barrier. And as soon as they get into central nervous system, they start to break or to impact and eventually damage hypocretin or orexin neurons. And eventually there is a significant loss of orexin with all symptoms. And that's why CSF test is needed, because you cannot detect it in blood. Orexin deficiency in type 1 narcolepsy. So what happens next? Going back to the picture that I just showed you in brain stem with all the nuclei, it's dysregulation, it's imbalance between activating processes and inhibition. So orexin is a protein that's needed for maintenance of wakefulness, and it's crucial for smooth transition between REM and non-REM sleep stages. And as soon as sleep is unstable, what happens, first of all, if it's responsible for staying awake, obviously, the person is excessively sleepy the next day. And what happens when the switch between REM and non-REM is not working properly? You imagine 4-year-old capricious child who runs to the light switch and starts to play with it. This is how narcolepsy patients' sleep looks like. I'm asleep, I'm not. I'm asleep, I'm not. Sleep is very fragmented, so that adds to the next day sleepiness. And also, there is a blurred margins between REM state and alert state. REM sleep gets into daytime alert state, and alertness gets into sleep during the night. So during the night, you see sleep fragmentation, which is crucial to distinguish between narcolepsy and idiopathic hypersomnolence. In idiopathic hypersomnolence, they have beautiful night sleep. In very classic narcolepsy, you will see a lot of sleep fragmentation. So they sleep, but they don't get enough. But there's sleep depression if they have a nap during the daytime. And what are sleep-related hallucinations? What is cataplexy? It's actually REM intrusions in daytime alertness, right? So normally, as we heard earlier today, in REM sleep, we are all paralyzed when we dream. So bits and pieces of that state, time to time, show up during the daytime and are very disturbing for normal functioning in narcolepsy patients. Here's another slide I find like from different angles. Let's try to understand what is going on. I think it's basically what I just already said. So for example, when cholinergic system is imbalanced, we have all those REM-related symptoms. And when dopaminergic system is impaired, we have daytime sleepiness, we have some autopilot behaviors. So a lot of narcolepsy patients will tell you, I'm zoning out all the time. I don't know how I got here. I don't know how I get through the day. And you see in polysomnography, obviously, the features that Kevin very nicely covered. Secondary narcolepsy, we should not forget about that. We should think about it. And this is something to think more about in adults when they present with narcolepsy symptoms. In children, certainly it also might happen. So one thing I would say, when you have somebody with cataplexy, loss of muscle tone without loss of consciousness sounds very suspicious for seizure, because as soon as seizure is generalized, as soon as both body parts are affected, both body sides, it means it's generalized, there will be loss of consciousness. And if it's not, you suspect cataplexy. We won't go deep into psychiatry, what else it might be, but there is quite a differential list, of course. And if you have cataplexy and focal neurological symptoms, you need to do MRI brain, you need to look for structural abnormality. It's very suspicious of Maybe it's something post-traumatic, maybe it's malignancy, maybe it's stroke, and also it can be infection. It also can be autoimmune or paraneoplastic encephalitis. And certainly can be in younger children for different causes, but also can be seen in adults. And here are a few examples of specific genetic syndromes. Niemann-Pick C can be seen in children and can get into adulthood, and a couple of other symptoms that are rare, but can be presenting with narcolepsy with cataplex. I think this would be what I had to say about overall pathophysiology, and now we will gradually shift into the management of narcolepsy, what we can do. And I like to look at it as any other condition, what I can do with, but also without medications. When we talk about pediatric population, you will hear it every day from parents. I don't want my child to go on medications. Nobody wants, right? I don't want to be on any medications either. I don't want my child to be on any medications. So let's see, where is the line where you start them on medications and what you can do without it? Well, here, good sleep hygiene is out of negotiation. It's a must. Without that, we won't get far. There is no medication that will help if there is a poor sleep hygiene. And that's a big, big topic in pediatric sleep. We are like broken record, right? So a lot of resources give to your patients, and we will do what we can. I also would like to echo, it's a team work. We will never get to a good narcolepsy management without good team. First of all, we won't even find it. We won't diagnose it, right? So narcolepsy can be fixed by different specialists, as Kevin also mentioned. Psychiatrists, we also think about it, endocrinologists, and et cetera, et cetera, et cetera. And then when it comes to the management, we need a strong team of, if we're lucky, we're thinking about social worker, psychologist, maybe psychiatrist, how we can support family. And this is probably the only condition where we actually, from sleep medicine point of view, we recommend daytime naps. Nap sessions can be super powerful. I just went to the conference in Europe, International Pediatric Sleep Meeting, and I will show you a couple of slides, snapshots from there. Dr. Greengrass, I believe is his last name, we will see it in a second. So he said, okay, we need to start somewhere. Write a letter to school. What do I write? How do you take a nap? 30 minutes? Is it 60 minutes? Is it 20 minutes? Is it twice per day? How many? So he said, right now I write a note. Allow this child to take a nap for 20 minutes twice per day in a quiet area. And it can be tremendously helpful. They can normally function just with that approach. And it's small, but big in a way. Now, we also need to educate patients and families and maybe even teachers to their communities that when symptoms get worse on certain treatments, it doesn't mean that narcolepsy is not controlled anymore. Narcolepsy is known to get worse in terms of symptoms when some infection is going on, or it's upper respiratory tract infection, or something stressful, it's exam session. And during those times, unfortunately, sleep attacks and cataplexy might act out. Sometimes maybe we can go a little bit high on medications for that time, maybe additional naps is all that what they need. But to know and not to panic, it doesn't mean that narcolepsy is not controlled anymore. Another thing I think in school age, at least I always bring it up, it's the time, let's say you have somebody middle school, maybe even high school already, and you diagnose them and you have this first educational session. I like to mention, okay, this is maybe a very good time when you're considering what you're going to do after school. Maybe don't choose a job which will require shift work. Maybe it's not a good idea to do something that will require night shifts or alternating shifts. Maybe it's not a good idea. I know how heartbreaking it can be, but maybe pilot is not a good idea. Maybe working at heights is not a good idea. Maybe it's not a good idea to choose the profession that requires driving as your main job and main income. And actually, I've seen a lot of very, very thankful looks from parents because they're, okay, yes, we actually need to think about it and take it into equation. Because narcolepsy people can be super successful, right? But you want to be very strategic in that sense. And there are a lot of resources, there are resources. And I like narcolepsynetwork.org site. It's from the United States. We also have our Canadian organization, Wake Up Narcolepsy. These two organizations provide a lot of supports. They have group therapy sessions or support group meetings. A lot of them are online. There are specific meetings for family members of narcolepsy patients. And speaking of caregiver burden or overall how the whole family dynamic changes, friends circle, etc., it can be absolutely priceless just to understand what's going on and that we are dealing with this and how we can do it. Understanding this means a lot to those families. And letters. I think everybody who worked with narcolepsy patients wrote quite a number of letters of support, and they can be sometimes quite silly, but can be super helpful to accommodate regular meals, regular naps, or sometimes just to confirm, yes, this child is not pretending they have narcolepsy. We always think about driving in younger children, less so, but of course, as soon as teenagers on horizon, it's a big part of my visits with teenage patients. When it comes to driving, they all want to drive, and you need to decide when it's safe together with the family and consider NWT testing. And sometimes those conversations can be unpleasant or stressful, but we have to mention that and to take care of it and think about it, of course. So this is one of the slides that I borrowed from the talk. I put a little bit, like this will be a short part of narcolepsy overlap with psychiatric comorbidities. As a part of non-pharmacological management, sometimes identifying what else is going on and placing appropriate referral would be, I think, important. So Dr. Paul Greengrass, I met him during this conference. He is actually a pioneer in a lot of things in establishing sleep medicine in the UK. And he is a pediatrician by background and did a lot of work in neuropsychology and runs sleep clinic. And he's absolutely amazing. You can Google him, you can find his articles, and he allowed us to take pictures of his slides, and I'll share with you a few of them. So here he presents how different parts of hypothalamus, those little nuclei, how they present with certain symptoms if there is a disruption in a network. And I think there is a lot of future potential, how we can be more specific, more target-oriented, treating anxiety in narcolepsy patients, treating depression in narcolepsy patients, or hopefully we will find a way to distinguish it, because right now it is a very gray zone and it can be extremely hard to identify, is it narcolepsy or is it mental health problem? So depression in narcolepsy, again, we don't know precise statistics. 22 to 32%, according to some literature, association between narcolepsy and depressive symptoms can be as high as 50%. And as I said, I think one of the most common overlaps I see when children come to me because somebody suspected narcolepsy, or parents just keep saying, look, something is wrong. We achieved some results with antidepressants, but still symptoms are happening and disturbing and interrupting. And maybe psychiatrist refers patients for sleep assessment. That's why you never want to do sleep study and then consult, because maybe it's not that easy. It's not so black and white. So depression certainly can mask narcolepsy symptoms. Narcolepsy can present as depression, especially if it's mild, especially if it's type 2. And as soon as those teenage people are put on SSRI, the diagnosis becomes extremely hard because SSRI group medications is a known REM suppressant, and then all your gold standard MSLT is ruined. Plus, not to forget, we also always need, and how much we can rely on that, 2-week sleep diary, because teenage people, if it's a young person who stays up until 4 a.m. and parents swear that they don't, there will be abnormal MSLT. You will see REM sleep because their sleep pattern physiologically shifted, and it can be very, very challenging. ADHD and narcolepsy, chicken or egg. Narcolepsy patients, they have interrupted fragmented night sleep, which can easily present during the daytime as ADHD-like symptoms. Is it ADHD? Oh, meets the criteria. Let's start them on stimulant. Now narcolepsy is kind of treated, but maybe to begin with it was not ADHD. So my dream, and I don't think I will be living long enough to see, please give us a blood test, okay? This is ADHD and this is narcolepsy, or some marker to find, because right now it can be not so easy. Irritability, oppositional behavior, close to 100%. And you can, of course, imagine, try not to sleep for a night or two and you will have the symptoms, right? When it's narcolepsy person, even children being optimistic, being curious, willing to play, willing to live their lives, eventually the symptoms will show up because they are constantly basically sleep deprived or having poor sleep quality. And how to manage it? This is from Dr. Rindra's slide. So you are planning regular nap sessions. You do not sacrifice the regular sleep hours. So you try to be as accurate, as cautious, even there is like event or party or something. And you can play with medications a lot. Like detailed dissection of how they take, let's say, modafinil or stimulant medication, timing, dosing, how you maybe can break it through the day, and it can bring us far. Exercise in the afternoon to stay awake. By dog, we all laughed. And then somebody asked the question that popped up in my mind, okay, what kind of dog? And Dr. Greengrass had the answer, golden doodle, I recommend. But basically dogs, they help the whole family. Well, in my case, it didn't help my family, but I don't have anybody narcoleptic, so we couldn't have a dog for too long. But I do see how dog can be the glue to the whole family when there is a lot of associated stress. And dogs can keep you very, very much on schedule, and they can be very helpful, not to mention a lot of positivity, but I guess they cannot be too funny, especially with type 1 narcolepsy. Peer support groups, CBTI has a lot of evidence, hard to get. That's why those online resources, publications, like with some booklets, they can be tremendously helpful. I found it was quite interesting, narcolepsy and schizophrenia. Adults with narcolepsy, in retrospect, we found that the risk is double than general population. Also, even in my not so long 10-year practice, I did have one patient initially, he was labeled in his teenage years with psychotic disorder, but actually it was sleep-related hallucinations. And he ended up having narcolepsy diagnosis. We treated it and it was a success story. Now, another situation where schizophrenia or psychotic disorders can show up in narcolepsy patients when you start them on psychotropic medications. You start them on GHB and they start to have psychotic symptoms. So then I think there is some genetic predisposition and this type of medications bring it up. This is just a quick slide, and you will have it in my handout about schizophrenia and risk factors. But what was interesting, according to some research publications, that if narcolepsy was diagnosed early, if it's in a context of high BMI, and also this genetic testing was positive. So these are 3 risk factors for higher rate of psychotic episodes in children and in adults with narcolepsy. So I thought it was quite interesting, but more so, hopefully, again, it will be our neuropsychiatry future. And now what we can do with medications, that will be a very smooth transition, I hope. So I think we can think about it. First of all, I would like to share our joy that we are living very interesting time dealing with narcolepsy, because right now already a few medications are available on the market that work specifically for narcolepsy, and they work really well, and they are very expensive and might be hard to get. That's why clear-cut diagnosis is so important. And yes, how related it's to clinical practice and management, but it's better to document effort score, cataplexy attack number, because start doing it, because insurances will ask these few questions, and you will not get medication approval coverage if you don't have that documented. So how to approach medication use? First, of course, you already addressed all non-pharmacological strategies and you explained to the family it can be crucial. It can be like night and day change. It's really worth to spend a lot of time to dissect it and say, like, look, it might be really, really useful in this young child to go on medication for many reasons. And then you think about what is the most impactful symptom. Is it daytime sleepiness? Is it sleepiness and cataplexy? Is it more like mild symptoms during the daytime, but you're convinced it's narcolepsy? So if it's the third one, you work on night sleep quality. But there is a group of medications for daytime sleepiness. And it's not so easy because for young children, not all of them are approved. And right now we have modafinil, which officially is approved plus, but is known to be used. I think 12 plus is a fair game. A lot of teenage patients are used off-label. And if I didn't mention earlier, a lot of things that right now I will be saying it is off-label, at least in Canada. Now, old, well-known stimulants actually are broadly used, but is should be the line, not these days, because we also have pitolisant, which is now approved in Canada for cataplexy, for type 1 narcolepsy, type 2 narcolepsy, but it works for both, for daytime sleepiness and cataplexy 6+. GHB and solriamfetol is approved only for 18+. I'm not aware of any projects right now or clinical trials that would explore it for younger children. And so far, I don't have any experience with prescribing it for younger than 18, but I probably would consider it 16+, maybe 15. And if you want to improve nighttime sleep quality, tryptophan might be a treatment of choice, and the old school zopiclone sometimes can be very helpful. Usually it's not where you start, but there is a room for this. And we need to be very, very mindful. DORA class new hypnotic agents is not the treatment of choice. It's contraindicated in narcolepsy. Now for cataplexy, GHB and old school antidepressant, actually tricyclic antidepressants are the most effective, but come with a lot of side effects. And NSSRI, SSRI can be used, plus comorbidity management. And I see that maybe I have 5 more minutes, so I will spend 1 minute on each medication. Modafinil, you start with 100 in the morning, and every 2 weeks you add 100, you do 100 and 100, and eventually you end up with 200 in the morning, 200 at noon. Can be a challenge for a school-age child to take a second dose in the middle of the day. But can be working very well, quite safe, low profile side effects, tolerated usually very well. And I think let's keep it simple. For all agents that fight daytime sleepiness, they're stimulating, so potentially they might cause headaches, jitterness, anxiety, palpitations. And more so in stimulant medications, you might need to control or monitor high blood pressure to avoid high blood pressure and cardiac arrhythmia. So modafinil can present with all of them, but it's really rare. Usually when you slowly, gradually increase the dose, it's tolerated very well. You do not want to give it starting with reproductive age. If somebody is relying on birth control or oral contraceptive pills, because modafinil can decrease the efficacy, and also it should not be taken when a person is pregnant for congenital malformations risk, and very rarely Stevens-Johnson syndrome rash can be triggered. Pitolisant, a revolutionary medication, very, very expensive and very, very hard to get the coverage. That's a very big obstacle, but when you get it, like, and especially here, there will be paperwork, there will be work with insurance, etc., and you will advocate for your patient. Very, very effective, approved for 6+ in Canada. And you also need to be mindful of body weight. So usually maximal dose is 20 milligrams per day under 40 kilograms, and then it can go up to 40. It comes in a tablet of 5 milligrams, 20 milligrams. Usually you start low and go slow. And this medication, it decreases or reduces the reuptake of serotonin. So sorry, histamine. Histamine is more active and it fights daytime sleepiness, but it also can be effective for cataplexy. Side effect profile is similar. Of course, it also can cause GI upset, and here rarely it can affect QT interval. And you need to be mindful there is some interaction with other medications through CYP2 D6 enzymes, so it can be used at a lower dose if it's taken together with medications like fluoxetine or bupropion. It can decrease the efficacy of birth control. That's another thing to keep in mind. Red flag. We remember all that. And here is a little picture how it works. And I think, oh, did I go back? Sorry. Next medication is GHB. Super exciting. If you ask me, first line, clear-cut narcolepsy, I would use it. I would use it for everybody as a first line. In States, it's approved for 7+, and in Canada, it's approved only for 18+. Strong recommendation, helps both, actually helps all of that. It helps nighttime sleep fragmentation, it helps daytime sleepiness, it also helps with all associated like hallucinations, sleep paralysis, and cataplexy. Very often it can be sufficient as a monotherapy, but there are a lot of challenges associated with this medication. So first of all, it's a super strictly controlled medication. As many of you may know, it's a day rape drug. So for these reasons and malicious use, it's very, very strictly controlled, which means paperwork for everybody who decides to work with it. And in terms of side effects, in my experience, usually it's tolerated very, very well. There might be some dizziness, grogginess, and nausea, and you need to take it with 1 crackers, like keeping a gap between dinner and when you give it. Another challenge, you give it in 2 doses. One is at bedtime, and second one is prepared for the midtime. You set alarm clocks 3 hours later because the half-life is very, very short. If you overdose it, then it's dangerous because it can suppress breathing function. And of course, there are lethal cases, and it scares everybody. So there's a lot of counseling around this medication, but there are also potentially possible some side effects because it's a very strong psychotropic medication. So I would be cautious if the story is not black and white, if there is some psychiatric overlay. It can be very, very tricky. And I had a few patients, maybe more in my young adult practice, when it brought up some suicidal thoughts in one case, some very, very significant anxiety and depression that was very disabling. So if there is psychiatric background, I would monitor them very, very closely, and I would be prepared that it might be not a good choice, but sometimes it's still worth trying. Until recently, there was a very good patient support program, but right now it's not there, and it's becoming more challenging to get the coverage. And here is again from the meeting that I recently attended, but it's kind of not really real, like we cannot apply it to Canadian patients. My youngest patient right now, I started him when he was 15. It was off-label, and the counseling was, I actually asked the boy to step out of the room. They were both parents, and I say, look, this is what can happen. I'm telling you in advance, like, so it needs to be locked somewhere, like teenage friends should not know about it. And the family was cooperative, and to this day, it's 3 years, it was life-changing. But I took the risk, I documented everywhere. I made them to write the consent forms that it's off-label in Canada. And in my fellowship, I had one patient, the youngest patient I had, it was actually off-label even by US standards. The boy was, I think, 3.5 when we started him on Xyrem, GHB. So there are a lot of obstacles to use this treatment, but it can be a miracle. It can be absolutely amazing. So if you consider having narcolepsy patients in your practice, please consider it. This is pharmacokinetics, and it is bimodal, so you can see it wears off very quickly, but there is new medication form, which is GHB 1 dose, didn't come to Canada, unfortunately, used in States. And this graph I wanted to show you, don't be scared, go high on those, because, okay, 6 grams works fine. There is a lot of improvement. Let's stop there. Try 9 grams. It might be even better. Maybe you don't need to add anything else, right? But again, considering patient's age and weight. So Riamphetol came to the market around 2020, works very well in adult population. I hope it will be approved for younger population. It's a norepinephrine and dopamine reuptake inhibitor, tolerated very well. One dose in the morning, 75 milligrams to start, 2 weeks later increased to 150. Not approved for under 18, used for daytime sleepiness. Another indication is for patients with sleep apnea and daytime sleepiness when they didn't respond fully to CPAP therapy or appliance. And no interaction with other medications, no problem with birth control, very well tolerated usually. And you might need to monitor heart rate and blood pressure. And the conditional strength of recommendation is for our well-known stimulants. You will have slides, so I will have it in my handout for you. And this medication's been around for a while, and you are very comfortable, 3+, 6 year plus to use these medications. So this is still a goal, number one goal in a lot of young patients with narcolepsy, and there is nothing wrong with that. And this is the same for different stimulants like Vyvanse. And also, sorry, there's one type of Vyvanse is put to next to the amphetamine, so it was an error. And I will share with you the slide. So this is basically the summary. Use of venlafaxine, SSRI, or tricyclic antidepressants is off-label when there is strong cataplexy. Let's say GHB helps, but there is still partial cataplexy. You are adding something from old school. If GHB works, but there is still residual daytime sleepiness, you combine with stimulants. You will have the slide from me. You will have this slide from me. This is European guidelines. I find this table can be very helpful. What is first line? Modafinil, pitolisant, solriamfetol, right? If it doesn't work, you switch to the second line. You start to be creative. And there are some medications that are off-label. And here are new horizons. So I hope GHB one-time dose will come to Canada. It's successfully used in Europe. It's successfully used in States for children 7+. And orexin agonists, they tell us that it's in pipeline 2020 plus, and we're still waiting. So hopefully one day. Thank you so much. Sorry if I went over time. I hope I confused you all. I hope I didn't make you sleepy. Together we can get far, okay? Thank you.
Yeah, you can see Arina and I are very passionate about this topic and could talk for hours. I think for sake of time, we'll just move on to our next talk.